Hello and welcome. This is Paula Fuller. I'm going to talk to you today about weaning from mechanical ventilation. My first slide is about the ventilatory criteria for weaning from mechanical ventilation. First thing we're going to talk about is vital capacity. One of the first things that we need to look about is what is the minimal number required for vital capacity. And that is for the patient should at least be able to achieve 8 to 10 milliliters per kilogram. One of the things that we use, of course, is the Wright's respirometer. You will see in the next slide the Wright's respirometer. Another thing that we look at is, of course, spontaneous tidal volume. Patients should be able to achieve 5 to 8 milliliters per kilogram. And that is, of course, based on the weight. And that is based on a tidal volume between 500 to 700 milliliters. The other thing that we look at is a patient's minute ventilation. The patient's minute ventilation, of course, should be less than 10 liters per minute for weaning, and also should correspond with the patient's normal CO2. One thing that we need to look at, of course, if a patient is a CO2 retainer. That CO2, of course, is going to be higher for our COPD patients. Oxygenation is another thing that we look at for weaning. Oxygenation criteria. The PaO2 should be less than 60 based on an FiO2 fraction of inspired oxygen of 40% or less. We also look at shunting. Interpulmonary shunt should be less than 20%. The ADA gradient we also look at should be less than 350 millimeters of mercury on 100%. And for every 50 millimeter difference for the AA gradient, there is, of course, an estimated 2% shunt. When we look at the alveolar arterial oxygen tension gradient, we always use that, of course, to estimate the degree of hypoxemia and the degree of shunting. It's very important to note the different percentages of shunting. 10 to 20% for mild shunt, 20 to 30% for significant shunt, and of course, for the critically ill patient that is in the intensive care unit, greater than 30%. We definitely want to make note of that for our patients in the ICU area. We talked a little bit about vital capacity, but let's make note of that again, especially for patients that are out on the floor, that have myasthenia gravis or Guillain-Barré. These are two of our most important tests that we will do, especially for on our boards. We'll see this. Students definitely want to take note of that. Vital capacity and the MIP or the NIF. The vital capacity is the maximum amount, of course, of lung volume the patient can exhale following a maximum inspiration. And again, that will be done with the Wright's respirometer. It can also be done through the ventilator. The MIP or the NIF is, of course, the pressure that the patient can generate in 20 seconds, and they should be able to generate a negative 20 centimeters of water. You and I should be able to do at least negative 40 to negative 60. Pulmonary measurements are very, very important. We always do, of course, our ESC, or effective static compliance, whenever we do our vent checks. The lower the compliance, the greater, of course, the work of breathing for the patient. Negative 30 centimeters of water, of course, it should be for weaning. We note static compliance every time we do a vent check. And we should be noting the number, okay, and note especially if that static compliance starts to drop for a patient. Raw is also very important, especially for our asthmatic patients. Normal is, of course, 0.6 to 2.4, and that's very important. I can't stress that enough for our asthmatic patients. Our VDVT and our is very important, especially for Bohr's equation. So, if you note, the amount of each breath that is wasted or not being perfused by pulmonary circulation is less than 60%. And that is, of course, our PACO minus PICO divided by PACO. Combined weaning, that is our rapid shallow breathing index, respiratory rate divided by the tidal volume in liters. Okay, and of course, greater than 100 suggests potential weaning. In most facilities, it should be greater than 100, but there are some places that look at the number 80. So take note of that. But again, 100 is what is listed there, but at some facilities, it is 80. The last slide that will deal with just general weaning procedures, I have noted there TP's weaning, and then of course there is SIMV, synchronized intermittent mandatory ventilation, where the patient can set his own rate, okay, along with, of course, the ventilator rate, CPAP, where the patient sets his own tidal volume and rate, and then, of course, pressure support, what helps to decrease the patient's work of breathing. Pressure support is a mode by itself or can be used in conjunction with other modes of ventilation. This concludes weaning from mechanical ventilation. Have a great day.